So here we are again. This is a very important topic for all MBBS students, all paramedical people, for all MD students, and basically for anyone who's a doctor or a paramedical professional. It's a vast topic. I've tried to keep it very simple and trying to cover the in the simplest manner so that everyone can understand what I'm talking about. I hope that everyone can see my slides. So these are the topics we'll talk about: why we must talk about TB, how to classify, what happens when there is infection, what are the signs and symptoms, how to diagnose, of course, how to treat, and NTEP and the vision and goals. Arvind? ये इसकी जगह पे ऑडियंस नहीं आ सकती मेरी, ये क्या आ रहा है?
मैम ये दिल्ली है जहाँ से कनेक्टेड है।
अच्छा ठीक है। So what is the global TB burden? When we talk about the importance of a disease, we must know why it is important. So the global TB burden is so much that in 2020, 10 million people fell ill with TB. Out of this, 1.1 million were children. Why I am talking about children is because children and adolescent TB is sometimes overlooked by their caregivers, health providers. It can also be very difficult to diagnose and treat at times. In all the 86% of these 10 million cases had actually come up in the 30 high TB burden countries in the world. So the rest of the countries had just 14%, 86% had come from these high TB burden countries. Out of these 30 high TB burden countries, there are 8 countries which account for 2/3 of the new TB cases. Out of this, India is the leading one. It's the number one. So in India, in 2021, the World TB statistics showed that 188 people per 1 lakh population fall sick with TB. 40% of Indians at any given time are infected with TB. Some of them have latent TB, some of them have active TB. What is active, what is latent? We'll talk about it later. India has the highest TB burden in the world, including the burden of MDR. We'll talk about what is MDR TB later. If you've heard of the term, then really good. India also accounts for almost 1/4 of the global cases, both the prevalence, which means at any given point of time, how many patients of TB are there in the world, and the incidence, that means every year, the new cases which get diagnosed. So India accounts for almost 1/4 of these anyway, all over the world. And worldwide, TB is the 13th leading cause of death. It is the second leading infectious killer only after COVID-19. And nearly 21% of the global TB deaths occur in India. The silver lining, however, every cloud must have a silver lining. We are talking about TB and TB control. So obviously, there have been some strides. So TB incidence globally has been falling at about 2% per year. And almost 66 million lives were saved in the last 20 years because of TB diagnosis and treatment. One of the United Nations Sustainable Development Goals, that is the SDGs, there's a list of SDGs which you can Google, and one of the health targets is ending the TB epidemic by 2030. After 2030, there should be no more cases of TB anywhere in the world, and if there are, at least there should be no mortalities. And like I said, TB is present in every country, every age group. However, the silver lining is that it is curable and preventable. So we'll talk about this more today. What are the ways in which we can classify TB? हमारे को हमारी ऑडियंस नहीं दिख सकती है? हमारे को हमारी ऑडियंस नहीं दिख सकती है? इसकी जगह ऑडियंस लगा दो, कोई दिखाई दे तो अच्छा लगेगा. Anyway, so coming to the classification and types of TB, I've kept it really simple. It's all very easy to understand. First of all, we have to know what is TB. So it's an infectious disease. I'm sure you all are MBBS students, you are all aware. It is an infective disease which is caused by a bacterium called Mycobacterium TB. This is a rod-shaped bacteria which is neutral on gram staining. This is asked very often, is it gram positive, gram negative? It is actually neutral. The property that this specific property that this bacteria has is acid fastness, which is because of the high mycolic acid content of the cell wall. So once the slide has been stained, it can no longer be decolorized. Therefore, the name acid fast bacillus. A lot of us in clinical practice are used to calling it AFB, acid fast bacillus. So this is almost like the nickname of the bacillus. So this is what the AFB rods look like. And once you see this under the microscopy, you can't forget that this is what they look like. This is a sputum smear that I'm showing, and this is what it looks like. I'm sure that the microbiology department in your medical college is going to show you such slides, and otherwise you can go to the nearest DOT center or the DOT microscopy center and again take a look at these. So what is latent TB? What is active TB? So not everyone who is infected with the TB bacteria becomes sick. This is a very important thing to understand who and when, like which TB patients should we treat. Like I said, in India, almost 40% of the population is infected with TB. However, not all of them would need treatment. So why so? Because not everyone who is infected gets sick or needs treatment. So there are two types of TB related conditions. There is latent TB, which does not require full-blown treatment. It may require some preventive treatment. Thank you. And then there is active TB disease. So what happens is that TB bacteria, they are very slow growing. They can live inside the body because of our immune system. They get limited once they are inside the body, and they may stay inside the body without making us sick. That is called latent TB. So in most people who inhale TB bacteria get infected, the immunity will sort of limit the bacteria, stop them from growing, and that is latent TB. Now these patients will have no symptoms. They are not infected. They do not spread TB to others. They may have a positive TB skin test or a positive TB blood test. We'll talk about this also later. They may or may not develop active disease. The lifetime risk of converting to active disease in these patients of latent TB is 5 to 10%, which is more often happens in those who have a weak immunity. So who are the people who are at high risk for developing active TB? First of all, one extreme of age, that is babies and young children. Then anyone who has HIV, somebody who's doing substance abuse, and therefore their immunity has suffered because of that. So anyone who has silicosis, that makes their lungs more vulnerable to being infected with TB if they inhale the bacillus. Somebody with diabetes, if there is severe kidney disease, if the body weight is really low, therefore again compromising the immunity. Anyone who has had organ transplant, they are immunosuppressed because of any other reason, they are on steroids, they have a malignancy per se and the treatment for malignancy. Both will make a person immunosuppressed. Then someone who's on treatment for rheumatoid arthritis or Crohn's disease, again, these people would tend to be immunosuppressed, and in their cases, latent TB would progress to active TB. The likelihood is small. A very important factor, which when it combines with TB, there is more chance of progression to active TB. This is TB and HIV coming together, and TB is one of the leading causes of death among people living with HIV. The point we should all know and remember is anybody with TB should be screened for HIV. We are doing this routinely in all our patients who we take up for TB treatment, and anybody with HIV must be tested for TB so that if active TB comes positive, treatment should be started. Likewise, TB and diabetes also, if they come together, then the chance of progression from latent to active TB is more in a diabetic patient. Then there's one more way of classifying, which is according to the drug sensitivity testing. So there is drug sensitive TB and there is resistant TB. In the drug resistant TB, there is MDR, XDR and pre-XDR. MDR is when there is multi-drug resistant TB, means TB bacilli are resistant to at least INH and rifampicin. These are the two most potent, most commonly used first-line drugs for the treatment of TB. So we must rule this resistance out in anyone who we start on treatment, because everyone would be getting INH and rifampicin. And if these two drugs are not effective, what is the point of treating the patient? The patient is not going to respond. So this is MDR. What is XDR? When there is resistance to both INH and rifampicin, plus any fluoroquinolone, which we use as a second-line drug, and at least one of the three injectable second-line drugs. There are many injectables that we use, as we'll talk about those later. There is amikacin, there is kanamycin, there is capreomycin. At least one of these three, if the bacillus is resistant to, plus a fluoroquinolone, plus INH, plus rifampicin. So four things the person is resistant to, the bacillus is resistant to, that is XDR. And then pre-XDR, like the term says, is in between MDR and XDR, meaning there is resistance to INH and rifampicin and either to fluoroquinolone, so तीन चीजें हो गई, और INH and rifampicin and a second line injectable, या तीन ये वाले हो गए. So any three things is pre-XDR, 2 is MDR, 4 is XDR. So the thing to remember is drug sensitive TB and drug resistant TB, they are spread the same way, the symptoms and signs are the same. There is no way that you can look at an X-ray or look at an ultrasound or look at a patient and say, "Arey, isko to MDR hai." No, it's a lab diagnosis. Only when the TB bacilli are cultured or another drug sensitivity technique is carried out, can you say that this is MDR, XDR or pre-XDR, or it is drug sensitive. We'll talk about this later. Now, depending on the site of infection, again, TB can be classified. This is very easy to understand. There is pulmonary, which is the main focus always of all programs, because this is usually the infective type of TB. So they can be pulmonary, which is TB in the lung, and extrapulmonary, which is TB anywhere else in the body. All parts of the body are affected by TB bacilli except hair and nails. There can be pleural TB, means the pleural covering of the lungs. So when the parenchyma is affected, it is pulmonary TB. When there is pleural effusion, then it is pleural TB, which is extrapulmonary. It's not pulmonary. It's not called pulmonary. There can be pericardial involvement, bone, joints, skin, GIT, genitourinary tract. There can be TB in the spine, which is known as pot spine. There can be TB in the lymph nodes. These lymph nodes can be cervical, axillary, inguinal, intra-abdominal, mediastinal, anywhere in the body. There can be meningeal TB, there can be tuberculoma, and sometimes when more than two sites are affected, we call it disseminated TB. For example, if a patient has both pulmonary and abdominal TB, or they have pulmonary TB and also lymph nodes all over the body, we would call it disseminated TB. As the name explains, it's TB which is spread throughout the body. This is another type of TB which doesn't come in the classification as, it's basically a type of pulmonary TB only, but this is something that everybody should know about. Like you can very well see on this X-ray that if you do the X-ray, there is a millet seed-like appearance all over all the lung zones of both sides. So this is miliary TB, millet seed-like opacities you see in both lung fields. Now, what happens when a person inhales TB bacilli? No, first of all, we have to talk about what happens when you get exposed to a person who's coughing out TB bacilli. So, from exposure to infection, what happens? One thing to remember is tuberculosis is always transmitted through the air, not by surface contact. We all know how in COVID times, fomites and surfaces were being talked about. Everybody was cleaning all the surfaces. Everybody was using sanitizer on all the surfaces and sprays on all the surfaces. So TB bacilli are not transmitted through surfaces. They are transmitted through the air. Basically, every time a person who has pulmonary or laryngeal TB sometimes, that person coughs, sneezes, shouts or sings, then he or she is throwing out infectious droplet nuclei into the air around him. These particles remain, some of them which are 1 to 5 microns in diameter, remain airborne for a long time, for several hours. So now Another person, say Mr. or Mrs. A had this pulmonary TB, they coughed or they sang in a room, and then that room air had these tiny particles, which some of them settle down, they are no longer infective, but some remain suspended in the air. Now Mr. or Mrs. B enters that room. So what happens? So depending on how long they are in that room, how much the person who had coughed out earlier, how infective were they, what is the microbacterial load in their lung, and whether they have cavitary pulmonary disease or not, depending on all these things. Suppose they had coughed out a huge number of bacilli. Now the second person who comes into that room and stays for long enough, when they inhale, they may inhale some of these bacilli, and they will go inside that person's body, and now that person is infected with TB bacilli. So less often people who are smear negative are infective. Smear positive are always infective. Smear negative but culture positive TB are less often infectious. However, even they can be infectious. We have to be mindful of this as doctors, as clinicians. We should know that, okay, this person's smear has now come negative after treatment, but culture is still positive. So there is some chance that this person still continues to be infected. However, those whose cultures are also negative, or anybody who has extrapulmonary TB, they are usually non-infectious. This is a question I get asked very often. Every time I diagnose a patient of TB, this is what the family members want to know, whether the person is infective or not. So this is the answer. Culture negative, extrapulmonary. These are essentially non-infective. So this is a pictorial diagram that the patient who has pulmonary TB has coughed. There are these droplet nuclei which stay in the air close to and around the person. They can be as many as 3,000 infectious nuclei per cough. And some of them will remain suspended in the air. When this other person comes very near this person or enters this room and starts inhaling, that person may now inhale these TB bacilli. Once they go into the person's body, whether they will cause latent TB or active TB will depend upon now the endogenous factors. So from infection till disease, now what will happen? Now this will depend on what was the TB bacilli load and the endogenous factors as to how robust, how strong is that person's immunity, the one who has inhaled these bacilli. If the person gets infected right away, gets clinical illness, gets active TB right away, then that is called primary TB. मतलब अगर 15 जून को उसने एक टीबी के पेशेंट के कांटेक्ट में आया, वो उस मरीज ने खांसा, इन्होंने उसको इनहेल किया और 22 जून को मरीज को, इस पर्सन को खुद को खांसी शुरू हो गई, इसका एक्सरे किया और उसमें टीबी निकला, या 30 जून को स्टार्ट हो गई, मतलब राइट आफ्टर द इन्फेक्शन, इफ दिस पर्सन गेट्स एक्टिव टीबी, देन दैट इज कॉल्ड प्राइमरी टीबी. बहुत सारे केसेस में क्या होता है, जैसे मैंने बताया कि ये उसके बॉडी के इम्यूनिटी द्वारा कंटेन हो जाएगा. दिस विल गो ऑन टू बिकम लैटेंट टीबी. फिर कभी लाइफ में यदि उसको कोई ऐसा समय आएगा दैट द पर्सन's इम्यूनिटी गोज डाउन, देन दैट इज द पर्सन दैट देन the person may get active TB. And a lot of people will not get active TB after inhaling the TB bacilli throughout their life. So, but in children and in those who are immunocompromised, this sort of primary TB is common. So now, signs and symptoms of TB will depend on the site infected. Pulmonary TB हमारा thrust होता है सभी programs का, because like I said, these are the infective patients. I think everybody is familiar with the symptoms of pulmonary TB. Some are because of lung involvement per se, and some are because of the systemic effect of the illness. So lung involvement से क्या होता है, खांसी आती है, खांसी में बलगम आ सकता है, खून आ सकता है. There can be cough, there can be hemoptysis. There can be chest pain also. What happens because of the systemic side effects? There can be fever, there can be night sweats, there can be weight loss, there can be fatigue, weakness, lack of appetite, everything that goes with a chronic illness. In this you can see in the X-ray, which is labeled as A, in the right upper zone apical region, there is a infection with TB. You can see a cavitary disease, a heterogeneous opacity which has got a cavity in the center. This is a thick walled TB cavity. This is very commonly seen. TB bacilli are aerophilic. They love oxygen, so they usually, the lung lesions are in the upper zones. In the X-ray called B, you can see lesions in both the upper zones. Bilateral, you can see the lesions of TB. So this is what pulmonary TB usually looks like on X-ray. What happens in extrapulmonary TB? They can be lymph nodes. ये lymph nodes गांठों की तरह से या तो मरीज खुद महसूस करता है कि नहाते हुए देखा, कभी छुआ हाथ तो देखा. They can be in the neck, they can be in the axilla, they can be in the inguinal region. या फिर मरीज के मम्मी, छोटे बच्चे जब होते हैं, मम्मी ने पापा ने नहलाया तो वो बताते हैं कि हमने इसको नहलाया तो हमें बगल में या गर्दन में गांठें महसूस हुई. उसके अलावा दे कैन बी पेन एब्डोमेन, सीजर्स हो सकते हैं, स्किन में अल्सरेशन हो सकती है, एपेटाइट, जैसे मैंने बताया एपेटाइट लैक हो सकता है, विमेन में स्कैंटी मेंस्ट्रुअल पीरियड्स हो सकते हैं, बाउल ऑब्स्ट्रक्शन, पेन एब्डोमेन, जॉइंट्स में दर्द होना, बैक एक हो सकता है जिसको हम पॉट स्पाइन कहते हैं जब डायग्नोज हो जाता है, हेडेक हो सकता है, पेनलेस हिमेचूरिया हो सकता है जब जेनाइटो यूरिनरी कॉक्स होता है. दे कैन बी कोल्ड एब्सेस. नाउ आई वांट टू टॉक अबाउट कोल्ड एब्सेस. Sometimes in one area of the body, the pus which is formed by TB bacteria, the liquefaction that it causes, it can collect in the form of a pus. However, as opposed to जो हमारे बैक्टीरियल इन्फेक्शन होती है जिसमें जो वो एब्सेस होती है वो हॉट टू टच और वेरी पेनफुल होती है, कोल्ड एब्सेस में ये सब चीजें नहीं होती. टीबी की एब्सेस में देयर इज नो वार्मथ, देयर इज नो रेडनेस ऑन द स्किन एंड इट्स नॉट एज पेनफुल एज अ नॉर्मल जिसको हम acute bacterial abscess बोलते हैं, pyogenic abscess जिसको बोलते हैं. So that is why this is called as cold abscess. So anytime we talk about diagnosis, first of all, in a high TB burden country like ours, a high index of suspicion is a must. I talked about the symptoms of TB, but TB can occur in a very indolent, very slow growing manner. So symptoms may be missed. कई बार हम अल्ट्रासाउंड में कुछ देखते हैं, फिर मरीज से वापस पूछते हैं तो हमें पता लगता है कि यस, द पेशेंट हैड दीज सिम्टम्स. द सिम्टम्स मे बी वेरी इंडोलेंट एंड मे हैव बीन मिस्ड बाय द पेशेंट. सो ऑन द पार्ट ऑफ अ क्लिनिशियन, अ हाई इंडेक्स ऑफ सस्पिशन इज अ मस्ट. सो टीबी का डायग्नोसिस थोड़ा सा कंफ्यूजिंग होता है कभी कभी. सो आई हैव for simplification divided into three parts. There is imaging, there is procedures and there is microbiological confirmation. Imaging में like I already showed कि patient को ने आके बोला मुझे 2 हफ्ते से खांसी आ रही है और मुझे बुखार आता है या छाती में दर्द होती है या खांसी में खून आता है. We can go for a chest X-ray, very easily available everywhere, very inexpensive, and you can pick up the TB opacities. Then ultrasound कर सकते हैं, abdomen का कर सकते हैं, joints का कर सकते हैं, CT scan thorax का, abdomen का, head का. This will show either ascites, collection of fluid, और liver या spleen में granuloma दिख सकता है, lymph nodes दिख सकते हैं. lymph nodes के अंदर जो hallmark होता है of TB, जो histopathology पे, that is necrosis, वो दिखाई दे सकता है. CT and MRI, likewise head का भी MRI भी कर सकते हैं. These are very sensitive tests for detecting TB which is in the abdomen or in the chest, or tuberculosis in the head, etc. However, these are expensive, usually available only in bigger centers. Not every patient can access this, and people in our villages or in primary healthcare setups may not be able to access these. While chest X-ray and ultrasound are easily available to almost everyone. Likewise, joints के भी X-ray, MRI कर सकते हैं यदि joint की TB suspect कर रहे हैं. Spine का भी X-ray या MRI कर सकते हैं. Very sensitive test. You will see on port spine a typical TB picture of destruction of the vertebra. Collection may be there in and around the vertebra, which can be aspirated also, and then we can use it for microscopy and culture. There are some diagnostic procedures which are used in the diagnosis of TB. These basically what we are trying to do is get some material which we can subject to either pathology, histopathology, or to microbiology, or both. सो वी कैन डू एन एस्पिरेशन अगर कहीं पे कोल्ड एब्सेस है, कलेक्शन है, या MRI पे हमें स्पाइन के आसपास कोई कलेक्शन मिलती है, अल्ट्रासाउंड पे इंट्रा एब्डोमिनल कलेक्शन मिलती है, इट कैन बी एस्पिरेटेड एंड सेंड फॉर फर्दर टेस्टिंग. बायोप्सी कर सकते हैं किसी जगह की यदि जरूरत हो. FNAC, सिंस यू आर मेडिकल स्टूडेंट्स, आई एम श्योर यू आर नॉट familiar with what is FNAC. FNAC is a very easy, simple procedure which does not need any prior testing or preparation usually. So all you do is take a fine needle and do the aspiration. It can be done from the lymph nodes, from port spine, from anywhere in the body that you are suspecting TB, and FNAC can be done. And sometimes something interesting that our gynecologist colleagues, for example, may, after doing a hysterectomy, the samples, the uterus or the fallopian tube or the cervix may show granulomas with necrosis, and they send the patient then back to us that this is the patient who has TB. So this way we get a diagnosis which was retrospectively. An interesting case report that we published was cervical TB in a woman. So she had, the gynecologist thought that it was malignancy, but it actually turned out to be cervical TB. When an endometrial biopsy was sent, it was seen teeming with tubercular bacteria and typical granulomas were seen. We put the patient on ATT, anti-tubercular drugs, and the patient was fine. Now, microbiological confirmation is the hallmark, is the gold standard. So either you can do microscopy and smear and ZN staining, Zeal-Nelson staining करके sputum को किसी भी सेंटर पर बहुत आसानी से देखा जा सकता है. Very easy to do, simple procedure, very easy guidelines are there, how to do, how to discard, etc. All this is available on tbcindia.org, and this is such an easy procedure that there are designated microscopy centers where trained lab technicians carry this out. Then there is something called nucleic acid amplification, which is a game changer in the management of TB, because you can get a sensitivity test report within few hours of giving the sample, and you need not wait for the culture. Culture, however, remains the gold standard. You can do liquid culture, you can do solid cultures, but in culture, the standard turnaround time can be as much as 4 to 6 to 8 weeks. So we have to wait around that much, and then sensitivity testing can only be done once culture is there. While in nucleic acid amplification, also known as CBNAT, Gene Expert, in this, the turnaround time can be as easy as early as 2 hours. So same day report can be obtained, and it tells us about rifampicin sensitivity or resistance, and rifampicin is a surrogate marker for INH. So right away we know about INH and rifampicin sensitivity or resistance. So like I said, that we know about MDR-TB right away. And then there is adenosine deaminase. This is a level which is seen in any collection. So we can do it in ascitic fluid, pulmonary fluid, or meningeal fluid. There are definite cutoffs which are given for every fluid and by different labs. Pleural fluid, which we most often send for ADA levels after aspiration, the cutoff is something around 40. So if a person has an ADA level of 89 in the pleural aspirate, then we are sufficiently sure that the person would have TB and should be started on treatment. Now, if those were the tests, then what is TST? What is the IGRA? TST or MON2 test is a test in which purified protein derivative, PPD, also known as TU, tuberculin unit, is given intradermally to a patient, and 48 to 72 hours later, the induration in the skin, not the redness, the induration is red, with a scale to see what is the size of the induration. This is a very less expensive test, and it does give false positive and false negative results in some situations. Neither TST nor IGRA are diagnostic tests. They do not tell the difference between latent or active TB, but they are very good corroborative tests. TST or MON2 is my favorite test actually, because it is of so low cost to the patient, and you get a test which you can corroborate with the rest of the reports. So this is how it is done. Intradermally this is given, a bleb is raised, and 48 to 72 hours with a scale, the total induration is read. What is the size of the induration? It can be 5, 10, 15, 23, 25 millimeters, usually within 30. Then IGRA is a blood test in which cell-mediated immunity to TB bacilli is seen. IGRA is far more expensive. You need someone to come and take the blood sample, take it to the lab. In the lab, it is analyzed. There is an assay machine which is used. Reagents are very costly. However, the turnaround time is lesser. You get the results within 24 hours, and it gives false positives less often compared to TST. But like I said, it's very expensive, and it does give false negative at times. So now we have diagnosed the patient, we know how the person got infected, and now in case we think that the patient has active TB, then how to diagnose. I have let this slide remain while I'm having water for the reason that you can all look at this slide. It's a very important slide. Everybody must remember this protocol. You can take a picture, keep it with you always, and look at the picture when you have to treat a patient. So the standard regimen for drug-sensitive TB is for 6 months. There is 2 months of IP, 4 months of CP. 2 months of IP is 4 drugs, INH, rifampicin, ethambutol, and pyrazinamide. And 4 months of CP. That's pyrazinamide is withdrawn, INH, rifampicin, and ethambutol are continued. Sometimes we will prolong one of the phases, more often continuation phase, in case at the end of 6 months we see that the patient has not fully got cured. So we can then extend the continuation phase. However, this regimen cures 90% of the patients. What happens with MDR? MDR, first of all, like I said, कि इसमें कल्चर या जीन एक्सपर्ट पर पता लगना चाहिए कि ये MDR है. इसमें we give kanamycin, levoflox, cycloserine, ethionamide, pyrazinamide, ethambutol. Kanamycin injectable है. You need not remember this regime. This regime is always given by people who are experts in TB care. But the reason I wanted you to see this slide is to know that in MDR TB, the treatment goes on for 24 to 27 months. Imagine how painful it is for a patient to be getting injectables for 2 years or more. So that is what MDR treatment is. Then there is also extended drug resistance and total drug resistance. These are XDR and TDR are also 2 terms which are used. And in these again the treatment will depend on what the bacteria is sensitive to finally, and what does the clinical expertise of the treating pulmonologist say. Only then would treatment be started. Luckily again there's a silver lining here, that there is a shorter oral bedaquiline containing regime which has come up in the last few years, and now it is being rolled out all over India. We have already started this on our center. It is given for 9 to 11 months. The initial phase, the IP in this case is 4 months. The CP is either 5 months or it can go up to slightly longer. So IP is 4 to 6 months, CP is 5 months. Bedaquiline is used for a duration of 6 months. So this is a new regime which has come up. So the people with MDR can also now get a oral regime, which is for 6 months. So what a relief to them. There is also another new drug which has come up. I have not put its name on the slides just so as not to confuse you people. There is something for delaminate, and even that is now being used in India under the TB program. Now people are going to say that when there is such a big burden of TB, why are we vaccinating our children with TB? Well, vaccination with BCG does have its place. It prevents severe forms of TB in children. So WHO continues to recommend neonatal BCG vaccination in high endemicity countries like ours. So all the kids must continue to take this. Now we come to the last part of the lecture today, what is NTEP, National TB Elimination Program. Every MBBS and MD student must know about this. What is NTEP? So, in India, there have been TB control programs since 1962. There were multiple programs, like one leading to another, for the last many decades. But the one just before this, which is RNTCB, I'll go back to those slides later. RNTCB, which was Revised National TB Control Program. This was in place till 2019, and this was doing very, very well. So after this, the government thought that, seeing the epidemic of TB all over the world, and especially the high numbers in India, we should now move towards elimination, not control. So we changed the name of the program to NTEP and upgraded the program. This came into effect on 1st January 2020. So under this program, the government of India has announced its plan to eliminate TB Mukt Bharat, by 2025. I talked about the Sustainable World Goals. In the world, TB is to be eliminated by 2030, but India has announced its plan to eliminate TB 5 years ahead of the world goal, by 2025. This is what the structure of the this thing NTEP is like. Right on top sits the CTD, that is the Central TB Division, in the yellow triangle. This is under the Ministry of Health and Family Welfare, and underneath are the state TB officers, district TB officers, then the TB units, and then the health facilities at the primary level. And they are all integrated. So what happened with NTEP? There are 4 strategic pillars. There is detect, मतलब detect and diagnose TB, treat TB, prevent करो कि और cases नहीं हो, and build upon what we have. So the key points in NTEP as compared to the earlier programs, कि universal drug susceptibility testing is offered to every patient who is smear positive. So by the, like I said, nucleic acid amplification test, CB-NAT technique, every patient who is positive on smear will get or culture positive, will be subject to CB-NAT, and quickly, within hours or days, the result will be there, whether they are drug sensitive or MDR, etc., etc., etc. Then surveillance system is in place in India, headed by the TB Institute Bangalore. Then contact survey is being carried out for household contacts and all the other close contacts of anybody who has infected TB. Nutritional support, thank you. Nutritional support is given to TB patients under Nikshay Poshan Yojana. Every patient of TB receives 500 per month directly into their bank account. So the person is getting, for 6 months of treatment, 3,000 rupees. In UP, we have also started another very unique program under the leadership of our Honorable Governor. Under this program, children with TB are being adopted by various families. So our own SGPGI faculty members and staff members have adopted children with TB and their families, and they provide them nutritional support, which is other than the 500 rupees under the Nikshay Poshan Yojana. So these people are provided hampers with, say, milk, fruits, protein powder, etc. So that the person's, suppose the person was malnourished, and that would also lead to a slightly weakened immunity. So while we are giving treatment free of cost, we are also giving treatment money under Nikshay Poshan Yojana, and then these kids are being provided support by outside people who are the SGPGI faculty and staff members. This is also happening in other medical institutes. So these people get nutritional support through them also from time to time. I would also add that this nutritional support goes a long way to provide not just moral support, but also the TB patients feel that they are not stigmatized. That was also a big problem, a big mental block. Whenever any kids had TB, they could not go to school because the others might think of them as infective and look at them with suspicion. So this way we are also removing the stigma when a doctor's family or a staff member's family is going and talking to those patients and talking to their families, providing them moral support, then they feel very confident about the treatment, and they feel that there is no stigma attached to the treatment. So what is Nikshay? There is a specific term called Nikshay. You can all go online, Google, and find this. Central TB Division has developed a case-based and best web-based system called Nikshay. So this is a portal into which every time a TB patient is diagnosed, all the details are entered. What is the name? What is the gender? What is the age? What is the address? What type of TB, pulmonary or extrapulmonary? How was it diagnosed? Is it a microbiological confirmation? Are TB bacilli, for example, seen on a smear or gene expert, or is it something which is clinically diagnosed, etc. So all these details go onto the Nikshay portal, and each person is given a unique ID called Nikshay ID, which goes on their card, treatment card, and this helps with not just the reporting but surveillance, monitoring of all TB cases, and notification of TB patients is a must. Every time any private practitioner or a government hospital doctor starts a patient on TB treatment, no matter what their method of diagnosis was or what the site of TB is, notification is a must. Okay, so what are the uniqueness of the Indian TB programs? There is DOTS and there is DMC. DOTS is that the treatment is given in front of someone under direct observation. Why so? Because the treatment is from 6 months up to 6 months. MDR, the treatment is up to 11 months, and patient gets better very quickly. Within first 2 to 3 months of treatment, the patient gets better. So the tendency was to stop treatment or to just waste the medicines which they are given. So to eliminate this, and that causes a lot of resistance because you are abusing the antibiotics and ATT. So to eliminate all this, to cause adherence to the therapy, this method was taken out, which is called DOTS, in which TB medication is taken right in front of a DOTS provider. Then there are some designated microscopy centers. For every 50,000 population, there will be one DMC. Sputum smear microscopy is conducted here. 2 sputum samples are collected. Earlier it used to be 3, now just 2. One a spot sample. Whenever the patient comes, they can give one spot sample, and one is a morning sample when the patient coughs out the first morning sputum properly and brings it to the DMC for smear, for microscopy. So that's the 2 type of samples are there, and this microscopy picks up a whole lot of patients. TB symptomatics, and this is very easy to carry out. All you need is a microscope and staining technique, and this can happen even in villages, and it is happening. And you just need to give the person some training, and then that person is ready to deliver. In NTEP, what happens is that drug dosage is as per different weight bands. Those charts are there. The DOT provider only needs to look at the chart to know, okay, this person should be given 3 tablets, this person should be given 4 tablets. ATD comes in the form of fixed dose combination that decreases the total number of tablets and improves compliance of patient. Dosage is daily. There is a concept of one patient, one box, in the sense that right on the day the patient is diagnosed and sent by the clinician for treatment to DOT center, that person, their one box is designated for that person. Okay, this is Mr. ABCD who got sick, this is his box. So throughout his treatment, the medicine is not going to fall short. The person will complete his or her medicine course because one box was designated to that patient right in the beginning. And the approach to treatment is patient-centric. We try to find out what suits that patient, what is the easiest method for patient to obtain treatment. There is also an approach now of active case finding. This is from our center. From 9 to 22 March, this was the ACA Pakhwada this year of 2 weeks. In this, our DOT center workers, our TB unit workers and we trained ASHA workers who go into the community. They were they had a questionnaire, and they were going from house to house and doing a survey and finding out who probably would have active TB, and then they would bring them to our center and we would get their testing done. So instead of waiting for the patient to come to us, we were actually going looking for the patients. So what are the visions and goals of TB treatment in India? The vision and goal, like I said, is of a TB-free India, TB Mukta Bharat by 2025, with zero deaths, disease or poverty because of TB. There are 4 strategic areas: detect, as in I talked about diagnosis. First, high index of suspicion, and second, diagnosis. Then treat, so that the treatment is given free of cost to the patients. Prevent, and build upon what we have. Intensify TB detection in susceptible populations, key populations like HIV patients, wherever there are patients of drug abuse, wherever there are patients of diabetes, wherever there are patients of silicosis. In these key populations, TB detection must be intensified. And any susceptible population, such as healthcare facility where TB patients may also be admitted, or you don't know the person admitted what is the status, then scale up airborne infection control measures. And also screening and treatment is given for contacts of all the people who have infective TB confirmed. TPT, which is TB preventive treatment, that has also come now into the program for latent TB patients who are who either have HIV or are in contact with infectious TB disease cases. For them, this program was launched on 24th March this year on World TB Day, of giving them TPT, that is TB prevention kit, TB prevention treatment. And so that brings me to the end of my lecture. Like I said, we envision a TB-free India, TB Mukta Bharat, and universal access to TB control services. Every person should have access to these services, and it should not cost the person anything, and the patient should be able to get treatment, diagnosis and treatment, and get cured. Thank you.